Well, thank you everyone for being here. I really appreciate you taking time out of your night to come out. It really is great to see so many of you. And I'm really excited to be here to talk about palliative care with all of you. As Nora said, I've got some prepared remarks, and I'll be telling you a little bit more information, and then we'll take a little pause to take some questions, and then we'll save time for questions at the end as well. So again, thank you so much for being here. So tonight, really, one of my main goals for you all is to be able to go home and tomorrow, when you're talking with your friends about this amazing talk that you've come to, that you're really able to describe to them what is palliative care and why would you want a palliative care provider to be part of your healthcare team. In doing that, I'd like for us to talk a little bit about some of the benefits of palliative care, and we'll focus a little bit about having palliative care involved early in a patient's course with their illness. We'll also talk a little bit about comparing and contrasting palliative care with hospice. And then finally, we'll talk about sort of the hot topic issue of the End-of-Life Options Act. So why don't we start by diving in to talk a little bit about what palliative care is and the role that we play here at Stanford. I'd love for us actually to take a moment just to sort of get a feel for who we are in the room, to actually take a moment and pair up. So somebody next to you or a group of three. And what I'd like for you to do is to try to explain what you know or what you think palliative care is to your neighbor. If you're thinking, that's why I'm here, I came for you to tell me what that is, that's okay. But tell them what at least comes to mind when you hear that word palliative care. Why don't we take 2 or 3 minutes to just share with your neighbor. We'll come back and it'll be helpful to hear what you'll have to say. All right, let's come back together as a group. And I'll just start by saying, if you said that palliative care is about holding hands, that's okay. That is what you will find if you Google search and Google image search palliative care. You'll see a lot of hand holding. I will tell you that we do a lot more than holding hands, but we are always happy to do that too, if that's what's needed. Why don't we start by hearing from some of the folks in the audience about what did you hear from your neighbor, or what did you share with them about what you've heard about palliative care, or what comes to mind when you hear the word palliative care? In the back.
You're not doing anything that you think is going to cure the patient, but you make them comfortable for however long they're left.
Okay, so it sounds like you've heard that it's not doing things to cure the patient, but it's sort of helping to make them more comfortable?
Yes.
Okay.
And you would start that earlier, like hospice care, I think of as being toward the very end, where palliative care might be a year before a person doesn't want to go aggressive, and so they just say comfortable.
Okay, thank you so much for sharing. Anyone else? Up here in the front.
One of my concepts of palliative care is as you are continuing on your disease, and I'm thinking of an older person, I felt I wanted somebody who was caring and looking at that end-of-life process that could help me put together all the individual doctors we've been dealing with. I wanted somebody who would look at the whole picture.
Great, so someone really sort of walking along with you on that journey, someone to help coordinate your care.
Right.
Okay? Yes.
I think of pain control or pain management that's delivered not with the intention of cure.
Okay, so pain control not with the intention of cure. Anyone else like to share? All right, well, thank you so much for sharing. I've heard some things that are really right, spot on, and a couple things I think that we're going to learn tonight about what palliative care is. So thank you for sharing, and we'll come back to this idea a little bit more. So again, I think thank you for those thoughts. And before we talk about sort of a concrete definition of palliative care, I'd like to just give you a little bit of perspective of how we in palliative care really see our patients. And I would say that we really look at the person beyond the disease. And as an example of that, when I see patients in my clinic, I think of them, if we're thinking of cancer as an example, as a person living with cancer, not as a cancer patient. I think of them as more than their diagnosis, more than their illness. Your other doctors also think about you in this way, but we are just sort of blessed with the opportunity to really focus on that, and that's where our focus is. Let's move on to talk about sort of, as palliative care doctors, this is like our definition that we really think describes us best. What I'm going to do is just read the definition. It's a little bit long, but then we're going to break down each part of it together so that we all really understand. So palliative care is specialized health care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life for both the patient and the family. Provided by a specially trained team, palliative care specialists work together with the patient's other doctors to provide an extra layer of support. Palliative care is based on the needs of the patient, not on the prognosis. It is appropriate at any age, at any point in a serious illness, and can be delivered with curative treatment. So some of this is probably different than what you have heard out there in the world, and that is why I am so glad you are here and why I'm so excited to be here, because this is a real problem that people don't fully understand all that we do. So let's go on and we'll break some of this down. So first, relief from symptoms and stress. When I think about symptoms for patients who come into my clinic, I tell them, I want to hear about anything that is bothering you and that's getting in the way of life being as good as it otherwise would be if that thing were not around. That's what I want to hear about. In our clinic, we typically talk about things like pain, shortness of breath, nausea, constipation, anxiety, depression, coping with an illness, coping with a new diagnosis, and the stresses that come along with that. Fatigue, poor appetite, weight loss, neuropathy or that nerve-like pain, and we also can focus in on caregiving. In addition to helping manage symptoms, we really work to improve quality of life for patients and their families. Quality of life is a pretty vague term, like what does that mean exactly? And we intentionally sort of use that term quality of life because we recognize that everyone is sort of individual in what they view quality of life to be. So we really see our job not as much about defining what that is for you, but helping you figure out what that means for you so we can help you go after it. So for example, some people come to my clinic and they say, you know what is most important to me? It is living absolutely as long as possible, regardless of what that life is like. I just want to be on this earth as long as possible. Other people tell me, you know what matters most to me is being pain-free. I want that to be the number one priority. Other people are more specific. They want to see their grandkids. They want to eat a hamburger. They want to watch Netflix, whatever it is. We don't care as much about what it is as that we've talked about it and helping you define that. And I'll also say that, of course, most of us want a bunch of these things. And that's also where we sort of work to help. How can we figure out how do we balance these things and how do we optimize what's sort of most important and really identify like the trade-offs that may come down the road. So just to make that a little bit more clear, a recent patient I saw in clinic has stage 4 metastatic cancer, so cancer that spread throughout their body. He's actually doing great. He's walking, swimming, spending time with his family. He's really happy. He's actually doing so good that his oncologist is thinking, gosh, can I give you more intensive chemotherapy that might give you the possibility of more time? And my patient is really sort of trying to weigh this. Like, do I want to go through more intensive chemotherapy that might make me feel a little bit less good, but might give me more time? So it's that type of sort of weighing that us as palliative care doctors and providers are really good at just sort of wading into the waters with you, walking alongside you in those questions, if you will. In this patient's case, the result is that I'm talking to that person's oncologist now and trying to get some more information about like what do those probabilities really look like and helping frame it for my patient. Like, will he still be able to do his swimming that he really loves? Will he still be able to do the things that give him the most joy? And can you tell me more about what that experience might be like? Certainly acknowledging all the uncertainties that come with that, but at least trying to provide more specific sort of patient-centered information for my patient. I'll also say that we really recognize that patients and families are a unit. So when someone comes to our clinic, we see it's the whole family as our patient and who we're going to be helping take care of. And again, your other doctors see you all, see patients in this way and see families in this way. It's just that we are really lucky to have sort of the time, space, staffing to live that out. So for example, when I see a new patient in my clinic, my social worker, my chaplain come in with me, and we are there together. So we sort of have that space again. And we even can sometimes see patients' family members in a visit all of their own, without even the patient being there, because we're fortunate to sort of have those resources to make that happen. I'll talk a little bit more about how we operate as a team. I've already alluded to this a little bit, but both for palliative care that's done in the hospital or in an inpatient setting for patients who are admitted, and in the outpatient clinic setting, we really function as a team. And the reason we do that is because we know that when you're living with a serious illness, there are physiologic or physical symptoms, psychological symptoms, social issues that come up, and spiritual issues that can come up. It really takes a team to sort of take care of all of those things. As a physician, I am not always specifically trained to address each one of these, but with my team, we're pretty good at sort of getting a handle on a lot of them. So our teams, both inpatient and outpatient, include doctors, nurses, social workers, chaplains, medical assistants, and we're very lucky to have child life specialists who can also help us with talking with younger family members of patients about their illness. Some people look at this and think, oh my gosh, I already have so many doctors and so many people I go to see, do I really have to have sort of all of this? And I really like how our social worker puts it. He says, you know what, we're gonna show you the menu, you can decide what's right for you and what you want, and we can help guide you if that's helpful. Another part of the definition that we talked about is this idea of an extra layer of support. So what does that really mean? We really see ourselves as an extra layer of support, not just for patients and families, but really for other doctors here at Stanford. Again, taking care of sort of all these issues, it takes a whole team. And we see ourselves as a collaborative partner. We don't replace a primary care doctor. We don't replace an oncologist or a cardiologist or a pulmonologist. We're here really to work alongside them and to collaborate in helping take care of the patients we see. And again, your other doctors may be very good at helping address symptoms like pain, shortness of breath. They may be very good also at helping you sort of weigh these decisions. We're here for them too when that gets to be a little bit too much for them. I think especially in oncology, I really like to think of ourselves as helping them be able to focus on your cancer-directed therapy. That is what they are trained at. I am not. But I can help sort of offload some of the work that they may otherwise be doing with the symptom management in our office. So that's really how we sort of work to support them while we're also supporting you. I'd also say sort of to the point of, can someone help to put together all my doctors to help coordinate that care? And that is definitely another role we play as an extra layer of support. So in my own clinic for a patient I've been seeing, our social worker has helped to get some equipment for them at their home, like a hospital bed, a bedside commode. And really our team just has the extra staffing and support to really be the folks to go after those things. And again, other clinics also do this and do a great job. We're just there to help out if it's getting to be too much. I think another major point, and one of the ones that I think is so often confused, is that palliative care really can be for a patient of any age, at any stage of their illness, and absolutely can be given concurrently with treatment that is with the purpose of curing an illness. So I just want to take one more moment to sort of say that again, because it is so often confused, and unfortunately even confused among some of our other colleagues in healthcare. So again, there's no particular age, diagnosis, prognosis, or treatment plan that makes you either particularly eligible or ineligible for palliative care. And we can definitely see you sort of anywhere along the path of an illness. Again, I just want to take you sort of into my clinic with me and just tell you about the patients that I see very regularly. People who have a brand new diagnosis of an illness. people who actually are cured of their underlying illness, and they may just still have residual symptoms from either their treatment or effects of their illness, even though it's already been treated and cured. I see patients absolutely who are receiving treatments that are meant to cure their disease, and we're helping manage their symptoms and do some of this decision-making with them. I see people who, unfortunately, were not able to cure their disease, but they're getting treatment that's helping to sustain, try to prevent the growth of their underlying illness. And we also work closely with people who are living with their illness, even though they're no longer receiving treatment that's targeting their underlying illness. So again, we really see the whole spectrum, and patients all over the spectrum are more than welcome in our clinic. So that was sort of a quick overview of palliative care as a whole. What I'd like to do now is to talk about some of the benefits of early palliative care. And again, I'm talking about early palliative care because that's sort of where the studies have shown that we can have the most and best benefit when we're involved from very early on. Among my palliative care colleagues, we often sort of joke around that if we were a pill, we would be worth millions. We would sort of be the next blockbuster drug out there. And part of the reason we say that is from this landmark study that was done in 2010, published in the New England Journal of Medicine, which is, for clinicians, it's sort of our holy grail of research studies are put out in the New England Journal. And in this study, the researcher looked at patients who had advanced lung cancer, so metastatic stage 4 lung cancer. And part of the folks who got standard care just sort of went to their oncologist. They could be referred to palliative care sort of down the line, or they received early palliative care, which means from the moment they were diagnosed, they got connected to palliative care and saw a palliative care provider every month throughout the sort of 36 months represented here. And what they found was that the patients who got early palliative care and consistently saw palliative care had a survival benefit of 2.7 months more than the patients who didn't see palliative care. This was pretty groundbreaking for the medical community. And I would say while the generalizability of this study is still sort of being figured out, meaning does this apply to sort of every diagnosis and every different way that palliative care is provided? That's not entirely clear. However, there have been multiple other studies that have demonstrated survival benefit when patients are plugged into palliative care early. Most recently, a meta-analysis was done. A meta-analysis is basically like a research study of all the studies that are out there in the literature to try to get a better sense of like, are we seeing something that's a real effect? And that meta-analysis also showed that in general, early palliative care could in fact lead to a survival benefit. I want to move on because in addition to this survival benefit, there are many, many, many studies of palliative care across many different illnesses, many different settings, and many different ways of delivering palliative care that have consistently shown many different types of benefits. So it's been linked to improved quality of life, improved symptom burden for things like pain, nausea, difficulty breathing, improved spiritual well-being, improved psychological symptoms, and improved satisfaction with care. For people who are hospitalized, often they are hospitalized less frequently, and when they are in the hospital, they stay for fewer days. And caregivers report less burden when them and their families are connected with palliative care. So I've talked a lot about some of the research studies that have shown this. I think still sometimes it's hard to get a sense of like, what does it actually feel like? There was a great New York Times article by Paula Spann back in 2016, and she sort of chronicles a family's experience with working with palliative care. I'll just take a minute to read this quick excerpt to hear the words of another family. They have become converts. It was quite a relief, Mr. Chen said. Our doctor listened to everything, the pain, the catheter, the vomiting, the tiredness. You can't bring up issues like this with an oncologist. Multiple prescriptions have made his mother more comfortable. A social worker helps the family grapple with home care schedules and insurance. Mr. Chen, who frequently translates for his Cantonese-speaking mother, can call nurses with questions at any hour. Challenges remain. Mrs. Chen still isn't eating much, but her son now wishes the family had agreed to palliative care earlier. So just another person's perspective about palliative care. Let's move on to talk a little bit about palliative care and hospice, and importantly, some of the significant differences between the two. So first and foremost, I very much want you all to be able to go home and tell your friends that palliative care and hospice are not synonyms. They are not interchangeable words. They mean very different things. Again, unfortunately, I'm not surprised that some of you that is news to you. Even among my brilliant healthcare colleagues, I often hear these terms being confused, conflated, and mixed up. And it's unfortunate, and we are working very hard to try to improve that. As this sort of graphic shows, this is like how I think about palliative care and hospice. Palliative care is sort of big and broad, as we discussed, managing symptoms, helping identify what matters most to patients. And hospice is a small part of what we're trained as palliative care doctors to do, a type of care that we're trained in. But hospice also is often delivered from a separate agency from palliative care. So for example, here at Stanford, we have robust palliative care services, but we don't have our own hospice. And that's true at UCSF, that's true in the Harvard system where I came from. Academic medical centers sort of don't typically have a hospice. They work with local agencies. We're gonna talk a lot more about hospice, but just to sort of say that here. So what is hospice? And hospice is also a super confusing term because it means a lot of different things, sort of depending on the lens that you're looking through. So I like to explain to patients, I think about hospice really as three separate things. One is it is a philosophy of care. Two, it's an insurance benefit. And three, it's really a set of services that can be delivered. So we'll break each of these down to explain what I mean. So one, a philosophy of care. So I would say that hospice is really good at focusing and it focuses on supporting patients for whom comfort and quality of life is the number one goal. That is when hospice is a good fit. In providing this care, hospice often asks for each patient for whatever lab, medication, procedure, treatment. They ask the question, is that making this patient more comfortable in this moment? If the answer is yes, hospice is going to do that and want to do that very badly. If that medication, procedure, test, lab, intervention, treatment is not helping promote the comfort of a patient, they're going to say, we shouldn't do that. And I say that, again, just to go back to the idea that hospice is a really good fit for patients who would be in agreement with that, to say, you know what, at this point in my life, given what's going on, I want to focus on comfort, and that is the most important thing to me. This is often a good fit for patients who have that philosophy, and that often means that they are less focused on going to the hospital or on pursuing interventions that might prolong life. I'll also say that as a part of its philosophy, hospice really wants to help support patients where they are most comfortable. Many people have in their minds that hospice is a place that you go. That is not accurate. Hospice can be delivered wherever patients are. For many patients, they want to be at home, and that is their ideal setting. And hospice is really good at that. They are primarily a home-based service. They also can see patients in a nursing home or in a skilled nursing facility. And on some occasions, patients are seen in a hospice house or home. So those do exist. It just actually ends up being a minority of patients that hospices see. Let's talk about hospice as an insurance benefit. One thing that's important to know is that it is covered by all insurance plans, including Medicare and Medicaid. As an insurance benefit, there are regulations and guidelines that hospices must follow in order to receive their reimbursement from insurers like Medicare. And the Medicare guidelines, and as you may know, Medicare guidelines kind of ultimately trickle down to all insurance plans, mandates that patients must have a 6-month or less prognosis to be eligible to receive hospice benefits. There is some very exciting work and some Medicare demonstration projects that are looking at loosening that regulation, which I think would be very exciting. But it's not here, not for prime time. This is sort of how it is practiced primarily. So I think another important thing to recognize is that especially, I think this comes up primarily for patients who are living with a cancer diagnosis, that hospice typically doesn't cover cancer-directed therapies like chemotherapy or immunotherapy. Although, again, a caveat here is that as things are changing in how healthcare is delivered and what's available, there is more and more variability about what hospices are willing to do and able to provide. So I add this bottom point just to say that discussions about sort of specific treatments are worth having, questions that are always worth asking. So again, a role that sort of we as palliative care doctors are happy to help out with. Next, we'll talk about hospice really as a set of services. So hospice through the insurance benefit is typically delivered through a hospice provider. Around the Bay Area, some of the big ones are Mission Hospice, Pathways, Vitas, Hospice by the Bay. If you've heard of some of those companies, those are hospice companies. And much like palliative care, hospice works as an interdisciplinary team. They have very much the same mindset of looking at the person beyond the disease, focusing on quality of life, and similarly, they want to help address all those potential needs that could come up. So their teams include a doctor, a nurse case manager, social worker, chaplain, volunteer, and on occasion, a home health aide, someone who could help with things like dressing, bathing, eating. I'll just make note that the nurse case manager is typically the point person for hospice service. That's the nurse that would be able to come to your home. They're able to sort of rally other supports if you need it. And again, most of hospice is delivered in the home. So it is home-based care, if that's what's desired and what makes sense for you and your family. An enormous benefit of hospice is their 24-hour nurse line. So this is part of the government mandate. They must have this in place. So there is one number you call, and you will get a nurse who will pick up the phone and can give you advice about what to do for whatever is going on at home. Often they will make sure that you have medications at home so they can give advice about what medication could you give for this symptom, how do you give it, what to do if that doesn't work. They also have the unique ability to send a nurse out on demand to the home. You can imagine there's lots of different agencies, so there's some variability in how quickly they can send someone. In my experience working with hospices, I've seen them get nurses to patients' houses within 2 to 3 hours, and I would say it is very rare that I heard about a case where it took more than 24. Another great benefit that I think is important for people to know about as they're thinking about hospice is that hospice has the ability to transfer to sort of a higher level of care if that's needed. So again, their focus will be, if comfort is the number one priority, hospice is a great fit. If they're unable to get a patient comfortable in their home, they will bring the patient to the hospital to get their comfort managed. In addition, for some people who don't want to be at home, especially in this last 6 months of their life or at the end of their life, they can help facilitate a transfer to a nursing home or another nurse facility. They can also do that if you start at home and care needs increase to the point where someone is needed sort of 24 hours a day to help with care. The hospice can see you in your home initially and then help get you to a place where there's a higher level of care. Hospices will prescribe all medications that you get while you're on their service. And they often have a delivery service that sort of works closely with them. So they typically can get medications out to houses within 24 hours. They also prescribe and provide all medical equipment that may be needed. So hospital beds, commodes, wheelchairs, they help to take care of that. And it's all covered and part of that insurance benefit. One important caveat to note is that they do not provide 24-hour care. So when people go home on hospice, it still sort of takes family, friends, other support if that person needs 24-hour care. Hospice, unfortunately, can't provide that type of support. Let's take a little bit of a break for some questions, because I know that was an awful lot of information about what is palliative care, what is hospice, how are they different. I just want to take a break. I know we don't normally do this, but I think it would be helpful because it was so much information. Any questions about what I've said so far? Yes?
So what can we do now when we don't need palliative care?
Yeah. And what types of things on your mind when you're thinking about, like, what types of issues are you thinking about?
I mean, it's just anticipatory.
Yeah. I think in terms of planning
Like supposing you have suddenly an accident,
yes.
and then you basically have become,
Great question.
Yeah.
Yes.
So then you require this sort of a care, and is there something that we can do in anticipation of that? I had one accident and I'm sort of really paranoid because of that.
Okay. I think I understand what you're asking. So I think an important thing to think about if you are thinking about planning ahead and sort of asking those questions, what ifs? What if I found myself in a situation that I never thought I would be in, but I have clear thoughts about the type of care I would want? There's something called an advance directive, which is a document, but it also really is about a conversation with your loved ones. That really is a time for you to be able to document in written form and to talk to your loved one about what is important to you. And potentially, if it's right for you, to set some limitations about the type of care you would want. So some types of decisions that come up in advance directives are making statements like, if I were only able to be alive dependent on a breathing machine, would that be something that you would want? That's sort of the types of questions that may get posed on advance directive. And I think that is something that everyone should have. I have one with my primary care doctor. In addition to that, I think it's very important that everyone has what's called a DPOA, a durable power of attorney, also called a healthcare proxy or a surrogate medical decision maker, lots of names. All of it sort of means the same thing. If there was ever a time where you were unable to communicate your wishes or think for yourself, who would be the person that could step in for you to help make those decisions? For me, that is my brother. I've told him, he knows what I want. Like, he is the guy to call. I really believe so strongly that everyone should have that. It is, and I often tell patients that it is the gift that you give to your family members when you complete that, and them enacting it for you is the gift they give you back. So I strongly would recommend that when you're thinking, what can I do now? An advance directive and assigning your DPOA or healthcare proxy.
Quick follow-up question. So is this covered by insurance, palliative care or not?
Great question.
In terms of, I understand those two things you mentioned, which are the instruments.
Yeah.
But, things like, should we be now doing anything to set up the insurance right?
Yeah.
And what if you don't have that much, you're an immigrant to this country, you don't have a huge family support system?
What I would say, if you feel like you would benefit from palliative care, especially here at Stanford, and we'll talk about how to sort of reach out and get connected to our clinic, you should reach out and get connected. We are very fortunate to be able to take care of folks who want to see us. We do sort of work on figuring out, like, does your insurance work with Stanford, and will it cover this service? So unfortunately, I'm not the most expert about that particular question, but if you are interested, you should definitely call and ask. And if we're not able to see you, hopefully we would be able to help to get you referred to if there's another healthcare system that could see you. But call and talk to us. Our patient navigators are quite good. I know you had raised your hand first. Did you have a question? Right behind the person who has a question.
I just had wanted you to repeat the question
Oh.
because I did, but you did.
Okay.
Thank you.
Sorry, just didn't want to skip over you.
I do have a question though. You said something about hospice doesn't work with chemotherapy. Could you say a little more about that? If you're getting chemotherapy, that means hospice doesn't come in, or? they don't provide it?
Great question. So, again, I think that hospice is a really good fit when comfort is the number one priority, and people are typically not pursuing treatments on hospice that are meant to target their underlying illness. So sort of from that philosophical standpoint of the definition of hospice, having chemotherapy that is often meant to sort of prolong life and not meant to make you feel more comfortable is often not part of the philosophical sort of underpinnings of hospice. In addition, from an insurance benefit perspective, hospices typically do not cover the cost of chemotherapy because it's not sort of in that philosophical underpinning that they would provide. In theory, you could pay for your chemotherapy privately and still have your hospice services, but that is for most people not possible, and I honestly have never seen that happen.
So in your group, if one has the insurance that fits your group, chemotherapy is covered?
Oh, absolutely. So you can be getting chemotherapy and see palliative care because, again, palliative care is not hospice. We don't have those same regulations that the hospice Medicare benefit has. So again, I would think...
So whatever insurance I would have away from hospice would be working financially with my chemotherapy.
Absolutely. If you are seen here at Stanford for your care, you can come see. Your insurance should cover our care at Stanford with palliative care. So again, just would think about sort of this model that you can be here with palliative care, getting curative treatment. Anything you're getting here at Stanford, you're still eligible.
So if you were at hospice and you needed chemotherapy, perhaps for some other reason, you would have, what kind of insurance would one need?
In those cases, people would typically, if they change their mind, let's say, so they enroll in hospice and said, I don't want to get treatment, and they change their mind and say, I do now want to pursue cancer-directed therapy or chemotherapy, they would typically disenroll from hospice and re-enroll back in their insurance plan of choice.
Is that difficult?
Not difficult. For the sake of time, let's go ahead and move forward because I want to make sure that we cover our topics that were promised to you. And we'll move on to review of the End-of-Life Options Act process and content. So before we go too far into the End-of-Life Options Act, I do just want to come back to our diagram as really a moment just to state we're the End-of-Life Options Act, abbreviated as EOLOA on most of my slides, is that it truly is quite a small part of what we do as palliative care doctors. So a whole lot that we do with palliative care, a little bit of hospice, and EOLOA is a very small amount of our work. You can see that I made EOLOA overlap with hospice because most patients who are enacting the End-of-Life Options Act are enrolled in hospice and connected to hospice, and certainly are eligible for hospice. Let's talk a little bit about terminology. You can tell in palliative care we love our words and what they mean and what they don't mean. A lot of people have heard the term euthanasia, and euthanasia, sort of in its strictest definition, really is quite specific and refers to when a physician administers a medication to intentionally end a patient's life with the mentally competent patient's explicit request. So a key part here is that the physician is administering the medication. Physician-assisted suicide or physician aid in dying, lots of hubbub and politics around what you call it. I'm going to use physician aid in dying for the rest of my talk. It's when a physician provides, at the patient's request, a prescription for a lethal dose of medication that the patient can, and really must, self-administer by ingestion with the explicit intention of ending life. So EOLOA, just to be clear, is not euthanasia based on these sort of formal definitions, and really is a physician aid in dying or physician-assisted suicide or physician-assisted death law. A little bit of background of physician aid in dying in the United States. Multiple states have laws in place, or at least have legal protections for individuals who are participating in physician aid in dying. So it includes Oregon, which has the most experience, Washington, Montana, Vermont, New Mexico, here in California, Colorado, Washington, D.C., Hawaii, and New Jersey. So what is the End-of-Life Options Act? It was signed into law on October 5th, 2015, and went into in effect June 9th, 2016. We took most of our language actually from Oregon's Death with Dignity Act. Theirs was very well done, and they're the state with the most experience. Our law here in California has a sunset clause, meaning that unless further action is taken, it will no longer be in effect in 10 years.
Only for 10 years?
10 years from 16?
I believe that's correct. I'm not sure. It could be 2015 or 2016. I'm not entirely sure. Let's just talk about who is eligible for the End-of-Life Options Act. So must be an adult, age 18 years or older, a resident of California, diagnosed with an incurable or irreversible disease with an estimated prognosis of less than 6 months, must have the capacity to make an informed medical decision for themselves, and very importantly, must be able to administer the medication to themselves, or at least control the flow of the medication into their bodies, like through a tube or a straw. Let's talk a little bit about the process. So this slide is going to show you sort of the main process for patients, and the next slide will talk a little about the physician side process. So first, an oral request should be made, and then at some point, a written request must also be made that needs to be notarized by like a public notary or confirmed by 2 witnesses, and that cannot be a member of your healthcare team. The second oral request made to the prescribing physician should be made at least 15 days apart from the first. A consultation with a second physician is required to confirm the diagnosis, the prognosis, and that the patient has capacity to make the decision. Here at Stanford, Palliative Care serves as this consulting team. And then if there are any concerns about mental health or an underlying psychiatric illness, consultation with a mental health specialist is required. On sort of the physician side, and once someone has gone through those steps, medications are prescribed and either sent or delivered to the pharmacy. Prescribing physician submits the paperwork to the public health department within 30 days of making that prescription. And then they ask that patients sign a final attestation form within 48 hours prior to ingesting the medication. And then physician completes and returns a follow-up form within 30 days of a patient's death. I'd like to talk for a moment just about our perspective and our experience here at Stanford and in palliative care at Stanford. And I think that this is fairly representative of what many palliative care providers have seen and have experienced with similar End-of-Life Options Act around the country. Not all statements about mentions of end-of-life options are about pursuing physician aid in dying. I would say we often see people who are thinking about it and it's on their mind. And there are a lot of other issues that we can take a lot of action to make better. And I say that because we really see that many of these requests are openings to conversations that don't always end up to leading to someone participating in EOLOA. I say that just to tell you really what our experience is. We still honor and respect patients who want to move forward with this process. We just like to also be able to do our jobs of trying to address quality of life issues regardless of what that patient ultimately ends up doing. We feel like that's part of our responsibility. So here at Stanford, our role in the palliative care division is, again, really quite a small part of our practice. We serve in consultation to other doctors, as I described earlier, and we ultimately aren't the ones who prescribe the medications. So we're coming towards the end of our time, and I just wanted to make sure that I talk with you a little bit about how you can come see us. We would love to see you. We have some brochures up here and some cards with our clinic telephone number. Unique among Stanford clinics is you can refer yourself. So you can call our clinic, let us know that you're interested in being seen. We'll do a little bit of investigation to make sure we're sort of the right folks to see you, or you might be better served at another clinic, but call us and we'll check it out. You can visit our website that has some more information about where our clinics are located. and the doctors in our clinic. You can also ask your doctor to make a referral. We have locations, Palo Alto here in the main campus, next to the Cancer Center on the main campus, and then in the South Bay in San Jose. We are also rolling out telehealth. So after you come for one in-person visit, we can see you through the computer, which is really nice. You don't have to come in for every single follow-up. And we offer a lot of telephone check-in. So please take a brochure and a business card before you go. And if you are willing, I would love for us just to take one moment to actually repeat the exercise that we started with at the beginning. So remember, I asked you to think about, to pair up with your neighbor, and take a shot at describing what palliative care is or why you might benefit from having a palliative care doctor. I'd love for you to take a shot at that again. So why don't we just take 2 to 3 minutes, talk with your neighbor, and then we'll come back and we'll take questions for the end. All right, let's come back together as a group. I won't ask you all to share for the sake of time, but thank you for participating in that exercise. I really hope that this was informative and an empowering session for you. Let's go ahead and take a few questions from the audience, and then we'll wrap up. I'm going to start up here, and then second right here.
So in order to go to be eligible for palliative care, that serious illness, does it have to be life-threatening?
I would say that that is the most common thing that we see, but it is not, again, it's not an exclusion criteria. So again, we see people who may have a life-threatening illness, but have gotten over that life-threatening illness, but continue to have symptoms or other issues related to that. And we certainly can see folks who have other illnesses, but it's having the type of impact on their quality of life and the type of symptoms or the type of decision-making issues that we talked about. That is okay.
Are there other examples besides cancer?
Definitely. So we see patients from, thank you, asking if there are other illnesses besides cancer that can be seen in palliative care, and absolutely. So we often see patients who have heart failure, liver failure, renal failure. We see people with neurologic illnesses. So really there is a wide range of things that we're used to seeing.
Like, someone that's been told that they need a heart transplant because their heart's in bad shape, or that, like autoimmune hepatitis. I mean, it's under control, but you never know how long.
Yes, so asking about if someone who might be thinking about having a heart transplant, that they have heart failure to the extent they need a heart transplant, or autoimmune hepatitis, which can cause liver failure. Those are great examples of illnesses that are serious, and we would love to be able to work with folks with this.
So far, like, symptoms are under control, but you don't know for how long. Actually.
Yeah, and I would just say that sort of we're here when you need us. It may be that having another physician when things are going really well may not be that helpful, and if things change, we're always here too. Next question.
Yeah, you did that chart which showed the 4 quadrants and the person in the center.
Yes.
The 4 quadrants were all palliative care, the essence of palliative care. Where are your doctors in that? And does palliative care serve just as I'm using the term broadly, a consultant to the person on what they can do or some services they can use, or are they the advocate for that person with their doctors? Because a lot of times there's not just cancer or renal, there's renal and heart and multiple things that someone's managing, and so where does palliative care fit into that kind of?
Yeah, I just want to summarize your question both for our recorded and just to make sure I understand it, but it sounds like you're wondering sort of one, I heard sort of what is the role of the physician within palliative care and like the context of the team, and 2, sort of how do we work when there are multiple illnesses or multiple issues that are playing a part in what the patient's going through? Is that?
Yes, except when you say physician, do you mean the palliative care physician? So I mean the physicians, the specialists, and the your internal medicine doctor. Is the patient, the person still working with their doctors individually and consulting with you, or are you helping to advocate for the patient in that
Great.
many times mess of a lot of inputs?
Excellent. So are we sort of serving a role just as the advocate? Do we sort of take over, or like how do we interact with the other doctors? Thank you. Great question. We really see ourselves as collaborative partners, meaning like you are I'm just going to use cancer as an example, if that's okay, because it is, we see that the most commonly. My patients absolutely still see their oncologist, and they come and see me. I help out with some of this decision making, some of the symptom management. I write my note in a consulting role to the other physician, and I tell them, hey, we're going to do this for pain, we're going to do this for sleep. This is what we're talking about in terms of what they're thinking about, where their illness is. Do we have that right? I can ask questions to them. So in that way, there really is this amazing and lovely back and forth that's sort of on a physician-to-physician level we have, which is hugely satisfying because I feel like we can really help answer those questions and help patients ask questions in a different way. So sort of in that collaboration, we also are advocates, which is a really cool part of our job, to be able to help people ask the questions that maybe they didn't think to ask, or how to word it in a way that's going to like hook someone's attention, or just ask in the right way to get the information that you're really looking for. So that is part of like the fun part of our collaboration and I think advocacy role. And for folks who have a lot of different physicians, it is pretty common for a palliative care doctor to try to help out, and our palliative care team to sort of help out in rallying everyone together, whether that's through, just communication, saying, I'm now connecting all of us together. Could we figure out like what is the next step, or who is taking the lead on ABC? Does that answer your question? Okay. Other questions here?
Did you just say that you prescribe medication?
We do prescribe medications.
Okay.
Yes. So, and just maybe to piggyback on that question from your prior question, is that there are times where we see patients sort of a one-time, like we can sort of handle their situation, give recommendations to the other doctor, and they can take that over. And more commonly, we follow patients quite intensively sort of up front, and then if things are sort of settling out, we'll space that out. And we sort of work together with patients to figure out, oh, should you keep seeing me? Do you want to keep coming in? Or are you feeling like you've got things are pretty good, and then maybe they don't come see us for a while? Yes.
Do you collaborate with the geriatrics program here?
Great. The question is, do we collaborate with geriatrics? So fortunately, we are actually sort of all, at least academically, housed in the same division. So we're primary care, geriatrics, palliative care. Certainly a lot of the overlap, I think we see both in the hospital and outside the hospital. So we are close partners. I would say that geriatricians also very good at seeing sort of person beyond disease, part of their mandate, thinking carefully about like what are the goals, what's most important. So we really share in that. I would say we are slightly different and maybe stand out in our expertise in symptom management and when decisions are really difficult. So similar, but a little bit different. And geriatricians definitely have expertise that we do not have about helping older adults and managing some syndromes in older adults that we may not be as good at. But we're happy to talk and can help figure out.
Another quick question. Are there particular terminologies or things that are good for us to include in an advance directive that, and to experts would be very clear about what we would really want?
That is a great question. It's a little bit hard for me to answer that because it's so specific to the person. I will share my favorite advance directive is called Prepare for Your Care. It was made by an amazing researcher at UCSF. There's a website. If you just Google Prepare for Your Care, it will be the first thing that comes up. The website is wonderful. It is made for people who maybe not used to using computers. It has a series of videos that walks you through. And sort of as you click along, it is filling out your advance directive for you. And at the end, you can print it out and give it to your doctor. It is really quite wonderful. And I think just ask questions in the ways that is accessible to patients, but also it somehow magically also gets at the way that we doctors think about those advance directives. So if I had to recommend one, I would say the Prepare for Your Care advance directive is superb.
I don't know whether this is a misconception or not, but when people have talked about the right to die option, I've been under the impression that it was actually seems to be geared toward people that have a terminal illness, and it's not really looking at people with Parkinson's-related dementia, where quality of life is very definitely declining. Am I right or wrong in that?
It's a great question. So the question is around if the End-of-Life Options Act can be used by people who have advanced Parkinson's or Parkinson's dementia, and do you have to have a terminal illness to use the End-of-Life Options Act? So one, you do have to have a life expectancy or a prognosis that is less than 6 months, our best guess. That should be confirmed by 2 physicians. So that, in terms of like a terminal diagnosis, there is a prognosis that is mandated to be a part of anyone who chooses to go forward with the End-of-Life Options Act. So people with Parkinson's disease, there are sort of criteria that help us know where people are in terms of their prognosis. And so if they have Parkinson's disease and meet that criteria, they could be eligible. One caveat to what your question was is if someone had Parkinson's dementia, they unfortunately would not be eligible when someone has dementia because you have to have decision-making capacity and be able to sort of manipulate the information and make a decision for yourself. So individuals who have dementia are unable to sort of manipulate that information, unfortunately, are not able to participate in this.
For palliative care, does Medicare pay for that?
The question is, does Medicare pay for palliative care? Medicare, so we talked a little bit about hospice, so that is definitely a Medicare benefit. And for palliative care, most, as far as I'm aware, that Medicare really should pay for palliative care. Again, I'm not an insurance expert, so I don't want to tell you the wrong thing. But I'd say most of our patients are using Medicare benefits, so I think that for most people, it is able to be covered. Maybe one more question? Yes.
About the end of life, if you've got that 6-month diagnosis and something changes cognitively for you, and so you have already received the medication, but now you're at a point where you technically are not aware, and if that's in an advance directive where you already have the medication and you can still orally take it?
That is a very tricky situation that I have not personally come across. And to be honest, I would want to talk with like our ethics committee to say, make sure I understand sort of what they would think about that. So I apologize, I don't have an off-the-cuff answer for you. That is, strikes me as very tricky, very challenging, but a question that we could try to pursue together for sure. Thank you for the question. Thank you. Thank you.